Next speaker, Dr. Ritesh Agarwal, sir. He's a senior endocrine surgeon working at Bombay Hospital. Thank you. We welcome you, sir.
Thank you so much, organizers. Dear Chairperson, esteemed delegates, faculty, I'm thankful to ISTS for giving me this opportunity. Intraoperative parathyroid localization in thyroidectomy, the recent advances. Since beginning of the morning today, there had been extensive discussion on parathyroids. Even I had presented a talk in the morning and some of the slides are repeated. So pardon me for that, for repeating the slides. Hypoparathyroidism, as I already told, it is one of the most common thyroid surgery complication, and it is one of the most important also. Prevention starts before the incision is made. We should choose the patient very wisely. The selection of the patient is very important, and indication should be genuine. Causes of injury to parathyroid glands are usually the devascularization, which is one of the most common cause when we are operating and damaging the vessels inadvertently while doing the dissection. Another point is when you are doing the inadvertent removal, you are not thinking that it is parathyroid, it is removed. Later on we found either on histopath or after checking the specimen it is parathyroid. Trauma to the gland directly or thermal injury by energy sources. How can we prevent them? Surgical extent, if it is a clear-cut benign thing or a low risk where lobectomy or hemithyroidectomy is sufficient, do it. No requirement for total thyroidectomy, then you are saving the parathyroids on the other side definitely, and very less chance of hypoparathyroidism. Surgical adjuncts we regularly use, and we found them very, very beneficial in preserving the parathyroid vascularity also, and parathyroid as a whole. Like harmonic focus, we are using it regularly. Fluorescein imaging, sometimes, it's really a beneficial thing. Nerve monitoring also helps because when we identify the nerve, at the same time we are also able to see, visualize the vessels also to the parathyroids, and in turn the parathyroids are preserved. Intraoperative PTH, sometimes it is beneficial. Some centers do it for academic purpose. Before surgery and one value or at regular intervals after surgery, the levels are compared and we find whether the parathyroids are preserved or not. If the values are less, then definitely find where the parathyroid is missing, either devascularized or removed with the specimen. Harmonic focus, we are using it regularly. Just a short video. We are doing the superior pole dissection. No ties, no sutures, no clips. Just stay close and at the surface of thyroid. Everything is preserved, either the external branch of superior laryngeal nerve, or this is the anterior dissection where external branch of superior laryngeal nerve is important. And it really gives a bloodless field. And when we do the posterior dissection, remove the capsule of fascia. Keep on lifting the thyroid up and medially. This is the point where you will find the capsule of parathyroid or parathyroid itself. Preserve it, it will get down. Organizers, when I am exceeding the time, please inform me. I will end my talk. Thank you. So if we see this picture, both parathyroids are preserved beautifully, which are shown with the green arrow, and the yellow arrow is showing the recurrent lesion nerve. We had lifted the thyroid upside with the artery forceps. Another short video. If you see, we are between the parathyroid and thyroid. My forceps is holding the fascia between the thyroid and parathyroid, and still I am going more medial towards thyroid and dissecting with harmonic. So parathyroid vascularity is preserved. Same time, one of my colleague, they are checking with for the nerve integrity by intraoperative nerve monitor. The stimulator probe, the black probe is there. Autofluorescence is a newer technique. Yesterday and today, extensive discussion on autofluorescence has already been done. There are basically two companies which are producing the probes for cameras for autofluorescence. One is Ehrlich, which is commonly used, and another is J&J. There's a difference in the quality of the images we have found personally. So the other one is producing a better quality of image. The yellow arrows are showing the bright spot, autofluorescent spot of parathyroids. This is another picture where the red spot on the IR is showing is the parathyroid. This is a case of coexistent parathyroid adenoma where it has taken the dye after injecting indocyanine. Another case where the parathyroid adenoma is there along with the multinodal goiter, and we have identified and removed it. So it is essential that before surgery, we should identify whether there is any coexistent hyperparathyroidism or not. Because what happens, suppose you are operating. During surgery, you found something larger. You had removed it. Later on, it was found to be parathyroid. And after surgery, it will give an intractable hypocalcemia. Indocyanine green dye. This patient had a concordant imaging. And the bigger one, yellow arrow, the bigger one was concordant on sestamibi 4D and sonography, parathyroid adenoma. But when we put the indocyanine green, there were two foci. One was the larger one, another one was the upper superior one, and we removed both. Both were proven to be hyperplasia on histopathology. Handheld gamma probe, sometimes useful in the recurrent surgeries, especially when the parathyroids are enlarged. But the single best predictor of low hypoparathyroidism rates is high volume experienced thyroid surgeon performing the operation. So it is not rare that we do extensive dissections for thyroid CAs, bilateral, lateral dissection, central compartment dissection, and this patient doesn't have hypoparathyroidism. We preserve the parathyroids even after meticulous dissections. Thank you so much. Any questions are welcome. I hope I have finished in time. Yeah, please.
Thanks. Very precise. I want to know about that where you have found two parathyroids, hyperplasia. Have you removed the other side also in that case?
No, because I put the indocyanine green. I checked the other side also. It was a bilateral neck exploration.
Okay, it was already a bilateral.
Yes. Any error? Should I leave that as? Thank you.